Hey everyone, what's going on? This video is going to go over part 2 of the physical therapy evaluation, the objective exam. Now remember, part 1, which was the subjective exam, is the prerequisite for part 2, which is the objective exam, and that's what this video is going to be all about. Now just so you know, remember, all the information and all those questions you're getting from the subjective exam is super critical because that's going to help drive your thinking and tell you what's the priority on what to test for your objective exam. Hey everyone, what's going on? My name is Justin Lee, Doctor of Physical Therapy student at APU and fitness coach. Here you'll find videos on fitness, physical therapy, and lifestyle that helps inspire self-change. This channel is all about lifting others and lifting weights. So let's lift for change, people. If any of this resonates with you, feel free to subscribe. All right, so this is how it works. In the objective exam, this is where the physical therapist instructs the patient on what to do. This is where the physical therapist puts their hand on the patients and moves them around and does these special tests to gather a bunch of information to rule in and rule out certain diagnoses. So at this point, when you do the objective exam, everything is fair game. So that means whether you're observing, whether you're analyzing posture, whether you're putting your hands on the patient to palpate them, whether you're looking at them for movement analysis, it's range of motion, manual muscle testing, special tests to rule in and rule out. All those things are going to be things that you are going to record and remember when you document later on. Now, in a full physical therapy evaluation, which I posted earlier, the patient is going to typically move from positions from stand, sit, supine, and prone. So the point of this is that you don't want the patient to really move around and stand up, sit down, turn around, lay down. Oh wait, I forgot something, stand back up. So as you practice, or as the physical therapy is more skilled, right, from student to actual elite physical therapist, you want to try to minimize the amount of positional movements. So when they're in standing, try to finish everything in your testing in standing, then you sit down and do everything there, in supine, and then prone. But of course, if you miss something, it's totally okay. You can have them lay down and be like, you know what, I want to test something else. Could you actually flip back over into supine so I can test something? So that's completely fine. But ideally, you want to try to have a smooth, that's something you're aiming for while you practice, is to have them go from stand, sit, supine, and prone. All right, I have 3 tips that I want to share when you're going through your objective exam. Number 1, you want to get everything as objective as possible. Meaning when you're doing a lower back range of motion, you want to try to either get your goniometer and measure there, or you can measure from how far the fingers are from the floor with the tape measure, or you can try to get to see where the hands go on their leg. Anything objective is as good as possible. In this video, I didn't quite get an objective measurement for lower back range of motion, but while I'm looking back at these videos, that's something I definitely should have done. All right, number 2, you want to know what their Aggs or their asterisk sign is. Basically, what that means is in the subjective exam, they told you, hey, this hurts. So in my example, my patient said, all right, number 2, you want to go off of their Aggs or their asterisk sign. Now, remember in the example before, in the full evaluation, the patient said it hurts when they stand or it hurts when they arch their back, right? So then that's your Agg or your asterisk sign, and that's something that you want to test in the beginning, get an objective range measurement of their range of motion. Then after you do your treatment, which is in part 3, which I'm jumping the gun right now, you want to recheck that and then recheck the asterisk sign to see if they got more range of motion. All right, last tip number 3, it's very important that you clarify that if they have pain, that it's that same specific pain that they're coming in with today. So sometimes when they're arching their back, they might be like, oh, that hurts, but it might be in a different part or a different region on the body. So you always want to try to clarify. If it's not really clear, you always got to ask, hey, is that pain that you are coming in with today? All right, I'm going to be using the PhysioU app on my laptop to guide me along this video. But while I'm in clinic or while I'm practicing, I definitely use the PhysioU app all the time. Now, if you're a current DPT student and you're having trouble organizing and clarifying your physical therapy evaluations, I would highly recommend looking into the PhysioU app. Now, if you don't quite buy in at this point, just watch the whole video and you'll truly see how powerful this app really is. The PhysioU apps not only took my clinical reasoning to the next level, but it really helped me out when I was on my clinical rotations or my internship. And the reason being is because sometimes you learn something and you forget, and when you're in the moment, you're like, oh shoot, I totally forgot how to do the special test for the shoulder. I totally forgot the movement analysis and the movement faults for the scapula. Oh shoot, I need to go back and review that. And instead of going through all the notes or all the PDF files, the PhysioU app is conveniently right there. So it's a very quick reference to be like, oh shoot, special test for shoulder impingement. All right, Neers, Hawkins, Kennedy, got it. All right, movement analysis or movement faults for the scapula, it's this. And it was just super convenient. All right, before we get into it, remember the subjective was the prerequisite to the objective, right? So the thought thinking process starts there. So right now, what we're gonna do together is we're gonna pull out informations that were really valuable from the subjective exam, and then I'm gonna explain why those answers were important for us or for me to know as I went on and as I'm going into my objective exam. So the first valuable information was that the patient stated that the injury happened about 3 weeks ago. That means that the patient is in the stage about the acute and going into the subacute low back pain category. Now, in the pain history or in the healing process, right? The patient goes from acute, subacute to chronic. So somewhere along those lines. And right now, the patient is in the acute, almost to the subacute. Acute lasts for about the first 3 to 4 weeks, and then from about the 4, 5, 6 range is around the subacute range. So for right now, the patient is in the acute/subacute. Now, the mechanism of injury was that the patient was lifting something. Now, that means that the mechanism helps you think about certain diagnoses that may come with that. So for example, lumbar facet syndrome or lumbar sprain or strain are typical for lifting activities and when they hurt themselves while lifting. Next, they're Aggs, right? So what's aggravating them? The patient said that standing for a long time or rolling over or twisting kind of hurts them. So that's important because sometimes if it's directional based, especially when it's in the lower back, you have to understand which directions or which movements are going to be most painful for them. And along with those Aggs, you want to try to find out those 3 things. You want to find out how long does it take for the pain to come on, how high does the pain go, and then how long does it take for the pain to go back down. Now, those 3 things are important because that teaches you what the irritability of the patient is. So that can tell you as a physical therapist, how hard can I provoke them and how much can they tolerate today? Next is their eases or their relaxing factors. And the patient said that sitting and walking are going to be more relaxing for them, or that brings the pain down. Now that's important because now sitting, you're more in a flexed position, and then walking creates mobility in those joints. So those are some things that are more indicative of certain diagnoses that you're already thinking of. Now, AM, PM pain or morning and night pain is important because it gives you some patterns of how the pain is presenting throughout the day. Like, is it only in the morning and then it disappears? Is it on throughout the day? This kind of tells you where their severity is at or how severe the pain is at right now. And then it can also tell you some things to rule out some red flags, like night pain might mean more cancerous. Now, lastly, what's important was that the patient mentioned what his hobbies were. Now, he mentioned lifting, cleaning. In the exam, he mentioned that he does golf. So these are some things where you're trying to imagine what kind of movements does it take to lift, what kind of movement does it take to clean things overhead, or when they do golf, when they're rotating. All these things are important because you want to help them go back into their hobbies or go back into their function, and you want to make sure that you're able to give them the adequate strength, range, and all those different things so that they can get back to what they were doing. Okay, so we're gonna move on to the objective exam part 2, but right before we do, If you have any questions so far in this video, feel free to comment below. And if you have received value already from this video, go ahead and smash that like button. Now let's move on to the objective exam. Okay, so I signed in on my desktop here or my laptop, and I already signed in and went into the ortho section here on the left side. But as you can see, the PhysioU app also offers different things like gait, neuro exam, MMT. If you're just starting out, this is a really good app to look at. But for now, we're going to be in the ortho section, and we are going into lumbar, right? I talked about the best apps for physical therapy, and PhysioU is definitely one of them, which I'll link here or in the description. So definitely go check out that video. All right, so now the next part, how I use this. So now we're in the lumbar section, and there's quick access things here. But how I use it is I actually go into clinical pattern recognition, and then I look here, and I go, okay, where is the pain? The patient stated that the pain was localized around the lower back on one side, unilateral localized pain. So right in this region area? Okay. How about going up?
Nothing.
No? Okay, anything going down the leg here, down the buttock, down the side of your leg, anything towards the front of the body?
No.
It's not radicular, or it's not referring down the leg at all. So let's click this one. Now, it tells you what diagnoses, the possible diagnoses might be in that certain region. So that's pretty cool. Now, after my subjective exam, I needed to think of top three diagnoses, right? And in my mind, I was thinking facet syndrome, which is on there. I was thinking lumbar instabilities, which is also on there. And then lastly, I was thinking about lumbar sprain strain. Now, the reason I picked lumbar sprain strain is because of the mechanism of injury, which was lifting, and that's also common. So those are my top three hypotheses. Okay, now, so let's dig a little bit deeper into what each diagnosis and how they clinically present. So I'm going to go into the facet syndrome here first, which is a mobility deficit category. All right, and then so see mobility deficit right here. And then so what I'm going to do is I'm going to go into clinical findings. This is really important. There's a video here that tells you a little bit more of how they present. But if you scroll down here, it's really cool because in the history, if you read, it says onset of syndrome is symptoms is often linked to a recent unguarded awkward movement or position, misstep, fall, bending, twisting, or lifting activity. Sounds familiar, right? Reported findings, acute low back pain. Remember, we're in the acute section, so there's acute, subacute, and chronic, but we're in the more acute stages right now. Reported findings, it's acute low back pain, buttock or thigh pain, duration, unilateral pain. Now, it tells you in the exam findings what you might find. So lumbar range of motion limitations, especially end range, side bending, or extension, which is where they were limited because they're limited by pain. So let me know if that brings on your pain or not.
Oh yeah,
That brings on your pain right there? Okay, so maybe your hands get about right here.
Yeah.
Okay, come back up. Next, there are restricted lower thoracic and lumbar segmental mobility, meaning in the joints by itself. Okay, a little stiff here. Any pain? Yeah, okay, good. Any pain? No. And how about here? No. Okay, good. And then low back and or related lower extremity symptoms are reproduced with provocation of the uninvolved lower thoracic, lumbar or sacral iliac segments using posterior to anterior pressures. Meaning you can reproduce their symptoms when you're pushing them from posterior to anterior. So if they're prone, if they're face down and you're pushing on them, that's posterior to anterior. And as you saw in my objective exam, when I did that, the patient said, "Oh yeah, like that's the pain right there." If one feels more than the other. Okay. All right. All right. Anything here?
A little bit of pressure.
A little bit. Is that pressure or pain?
I think more pressure.
Pressure. Okay. And how about here?
Yeah, that one feels more like pain.
That one, is that kind of the pain that you're coming in with today?
Yeah.
Okay.
Yeah.
All right. And then I'm going to go up a couple more, okay? How about here?
Yeah, that one's more painful.
More painful? Yeah. Would you say that's more painful than the other one?
Yeah.
Okay. Yeah. Okay. And how about this one?
That one's a little less. That one's just pressure.
Not as much? Okay. All right. And then how about here?
That one's just pressure.
Just pressure as well. Okay. All right. Okay. So all of this kind of fits the clinical picture of what the patient presents like. So in my mind, I'm thinking, okay, facet syndrome is kind of high up there on my list. I still have the other two to go through, so let's go to that. All right, so next we're going to go back, and then we're going to go to lumbar instabilities. This goes into the low back pain with movement coordination impairments category. Now, clinical findings, we go here. We're in the acute-ish stage, right? And so now the history, let's look at this. Numerous episodes of low back pain in recent months. I didn't ask that if they had pain prior to this, so we'll have to kind of skip over that. Patient often reports significant pain after trauma or sporting activity or lifting. Okay, that was kind of the mechanism of injury. Patient reports having difficulty maintaining pain-free mid-range positions while performing activities, which is kind of true. The patient said it's hard to lift things, leaning back kind of hurts, and turning kind of hurts. So mid-range positions, it's hard to hold that. Now, reported findings, acute exacerbations of reoccurring low back pain and associated referred lower extremity pain. Now, referred might mean it's not just in that one region. It might refer down into like the butt or down the leg. So maybe not with this one. Exam findings, movement coordination impairments of lumbopelvic region with low back flexion, extension, or rotation movements. Maybe. Low back and or low back related lower extremity pain at rest or produced with initial to mid-range spinal movements. Well, they didn't really have referred pain like we talked about, or related pain like we talked about, but they did have pain in that mid-range, so that could be it as well. And then low back pain or referred pain or related lower extremity pain reproduced with provocations of involved lumbar segments, which is true. When we pushed them, right, or when we took them into extension, they were having some pain in those areas. And then lastly, possible segmental hypermobility, meaning it's moving a lot, along with symptom reproduction with manual examination procedures such as posterior to anterior pressures over the lumbar spinous process, which is that same thing when they're prone and I'm pushing on them. Yeah, that might hurt. So this is also a little bit on the list as well. So that's why it was my second hypothesis. Okay, last one. Let's go into lumbar sprain strain. This one is not in this category. So that one, I'm going to go into all diagnoses, and I'm going to look at muscle strain, which is also the movement coordination impairments. So clinical findings, history, numerous episodes of low back pain in recent years. I didn't ask that. Onset of this episode related to recent unaccustomed repetitive bending or lifting activities. Okay, well, there you go. Another lifting activity. He was moving and cleaning. He could be lifting a lot repetitively. An unexpected strain, usually while lifting or pushing, or a direct blunt trauma to the low back. I don't think he got hit, but he was definitely lifting something. Okay, reported findings, acute exacerbation of recurring low back pain and associated or referred lower extremity pain, pain in low back with movements, especially with forward bending or lifting activities or moving heavy extremities, like lifting the leg out of the car. Exam findings, movement coordination impairments of the lumbopelvic region with low back flexion and extension movements, pain with contraction of lumbar extensors, pain with activities that stretch the involved lumbar musculature or ligaments, low back pain and low back related lower extremity pain at rest or reproduced with initial to mid-range spinal movements. Let's go back to that other bullet point. Pain with activities that stretch the involved lumbar musculature or ligaments. So when I was thinking, the patient, when they bent forward, that's kind of putting the ligaments on the posterior side or the muscles on the posterior side on stretch, right? And when I did that, the patient said, this actually feels kind of good. Like, I don't really have pain when I do that. What I want to see is I want to see you reach down and touch your toes.
Okay.
Okay. And any pain with that?
No, that actually kind of feels a little better.
Feels a little better. So then that tells me, maybe this one is not really as high on my list. And the fact that it feels better, you know, when you're in lumbar flexion, that actually helps open up those facet joints, which gives it more space. And typically that feels better if the joint is more involved. So then because of that, because of flexion felt better and then extension kind of hurt a little bit more, I'm already thinking, all right, maybe this guy has more of a facet syndrome kind of deal here. Okay, so now these are the clinical findings that you should already have memorized of how each diagnosis kind of presents, so that when you're going through the objective exam and actually going in to test them, move them around, you should already have a clinical picture of, all right, they're kind of fitting this pattern, they're not really fitting this pattern, and so on. So what we're going to do now is we're going to go through each of those diagnoses and look at the key findings that are really important or that you should definitely look for in these diagnoses. And this is honestly the golden nugget, like the coolest part of these PhysioU apps, especially in the ortho section, because it gives you such an organized way of, all right, this, and this is what you should be testing and looking for. These are the key things that are going to be most important. Now, this is important because for those of you who are in ortho, it's like, it's like boom, like there's so much information and you learn everything so fast. It's like, how do I organize this? What do I test? Like, I don't really, it's like, it's so much. So this app is it's so powerful because it teaches you, all right, this is what you're going to look for. And then once you start getting the hang of looking at those key findings, you built that foundation so that when you start learning on top of that, then you start excelling and building and building and building, and you grow as a clinician as well. So let's go back into the facet syndrome, right? So I'll go back to where we were before, unilateral localized pain, facet syndrome. And now this time we're going to go into the physical exam, which is also known as the objective exam. So we're going to click that and we're going to click the key findings. Now there's a clinical reasoning tab here that you can look at, and it'll play a video on what that looks like. Definitely worth educating yourself on with that video. But for now, we're just going to go into the what you're going to look for with the facet syndrome. So for a facet syndrome, you're mainly going to look at lumbar mobility assessment. Because this is a mobility deficit category, you want to look for areas that are deficit in their mobility, right? So you're going to look at physiological mobility, which means your active range of motion of touching your toes, arching back, side bending, and then rotation. So those are the things you're looking at here. And then also accessory mobility, meaning like right at the joint, how does it move? So you're going to look at the central PAs, the posterior to anterior. So that's just going along the spinous process. And then unilateral PAs, which goes along the facet joints, and a little bit more specific to that source tissue. Now, when I did all of these brought on the pain that the patient was presenting with. So extension was hurting, some side bend was hurting, some rotation was hurting, right? When I had them prone and when I was doing PAs, when I got to that section, like I think it was L3, L4 area, especially when I did the unilateral, that was like, ooh, that really brought on the pain there. So with all of these, it helps me rule in a facet syndrome diagnosis. Okay, so that's that. We are going to move on and we're going to go back. Let's go unilateral and then go back to lumbar instabilities. Now, physical exam, what are the key findings you're looking for? You're going to still do the lumbar assessment. So you have your active range of motion, touch your toes, arch back, looking for accessory mobility as well. But now we have a clinical prediction rule for stabilization. So that means prone instability test is going to be a big one. Remember at the end when I had the patient at the end of the table, I was pushing on them. They said they hurt, they lift their legs, and I pushed it on it again. If they had no pain after they lifted their legs, then that would be a positive test. But because they continued to have pain even after they lifted their legs, that means that test was negative. I'm going to press there. Yeah. Is that the pain right there?
Yeah.
Okay, all right. So I'm just going to keep my fingers there. Can you lift your legs up? Okay, any pain with that first off when you start activating the muscles?
Nope.
Nope? Okay. And if I press down, does that make it feel better, worse, or the same?
I think the same.
The same, still painful?
Yeah.
Okay, all right. And relax. I also did a straight leg raise on them, and they did not have excessive flexibility. Meaning, because, and they didn't have aberrant motions as they were coming back up from flexion to stand. Because of these things, and all of them ruled out as negative, when I'm looking at this, I'm going, maybe likely that hypermobility is not their diagnosis. Get it? So last one, we're gonna move on into the I was thinking about the lumbar muscle strain. So we're gonna go into the physical exam, look at the key findings. Lumbar assessment, there you go again. There's your physiological mobility and accessory mobility, touch your toes, do your PAs. Clinical prediction rule for stabilization. So same thing, you have these same three things, and yeah, they were all negative. And then the last couple ones, you have your erector spinae and quadratus lumborum palpation. When I was feeling for the patient, I was just kind of more superficial instead of deep into the joint. If they had a muscle strain as I was palpating there, they would have hurt. They would have said, ow, like that brings on my pain, right? And make sure it's the same pain. But as I was doing it, patient said no, it didn't hurt. And then so pain with activation as well, prone hip extension, or anytime they use those musculature like the paraspinals, that should bring on their pain. So it's kind of like a 2-for-1. When we did the prone instability test, they were holding and they were lifting their legs up. Their paraspinals were firing and they were turned on. And if they had a muscle strain or sprain, typically when you do that, that should also bring on some of their pain as well. So now we went through all three of those diagnoses. We had the facet syndrome, lumbar instabilities, and the muscle or the lumbar sprain strain. And you can tell when we went over those key findings, when we looked at all the facet syndrome stuff, all of that was ruled in positive things. The lumbar instabilities, when we looked at them, they were negative. And then lastly, for the sprain strain, a lot of those tests were negative as well. So you can definitely say that, nope, these two, they were not it. So then I'm thinking, all right, that patient has facet syndrome for their diagnosis. Okay, that concludes part 2 of the physical therapy evaluation. Next up, we're gonna move on to part 3, which is the treatment, and I'll go into more detail of how I treated the patient. But make sure you don't miss when I upload that. So make sure you subscribe and then turn on that notification bell to get a notification when I do upload that video. If you found this video helpful and you got a lot of value from it, give this a thumbs up. And if you're a physical therapy student right now going through ortho, or if any of you and or your classmates are going through ortho and you're struggling to just get by, struggling to organize your information with all those tests and all those skills that you're learning, help a brother and help a sister out and share this video with them. So, are you guys convinced about the PhysioU app? Pretty damn powerful, right? It's like having all this knowledge bombs in the palm of your hands. You know, they have this web app, or they have this app version in the desktop, the laptop, the iPad, and on mobile. So it's like you can literally access it anywhere you go. It's super convenient. It has a very easy interface to go through. So you could definitely check that out. I'm gonna put in the link below. And the best part is that they have a free trial, so it's risk-free. Try it out for a couple of days. I don't know if it's 5 days or a week or anything like that, but try it out and you'll really realize, like, damn, like this is powerful. I can use this to help organize my thoughts, and I can use it to help myself in clinic. And when I'm getting ready to study for the boards, I can really look at this and have a quick access to, all right, like these are the things that I should be looking for. I hope this video helped inspire some self-change to become a boss at physical therapy. Now, I hope you understand, like right now as a physical therapy student, you are grinding through and you are just trying to get through classes. But just realize that your investment right now into your education and how much you're learning now and absorbing is gonna be so worth it when you go out into become a physical therapist or throughout your internship. Because if you invest hard now and just avoid just getting by, you're gonna be able to work on this patient that much more to get them not only just to get by to their prior level of function, but to go beyond that and make them into a better and more refined person than when they came in. So I believe in you guys. I know you can do it. If you have any questions, feel free to reach out, you guys. Change people, change people. That's why we live for change, people. Have a great one, you guys.